Good morning, everyone. It's Melanie Mock from Kentucky Hospital Association. I'm joined by my colleague Emily Henderson and Claire Arant. Thank you so much for joining our Kentucky SOS webinar today. We will get started in just a moment with Dr. Greenlee. First, just a few housekeeping. We ask that you do put your phones on mute today by hitting *6 or the mute option on your phone. We are recording the call today and we'll have it posted to our website. We also ask that you please not put us on hold, as we will hear your background advertisement or your hospital music. We will be, as I said, recording the call today, and it will be available on our website a few days after this presentation, so that anyone that missed it or you want to share it with anyone within your facilities, you're able to do so. You can also download the presentation at any point in time by going to the media library, which is the third icon at the top right hand of your screen. You'll go to shared files and then you'll go to download. Again, we will make these available to those participants today on the call, along with the CEU information. At this time, I'm going to turn it over to my colleague, Emily Henderson, who will do a brief introduction of Dr. Greenlee. Emily?
Thank you, Melanie. Kentucky SOS would like to just give a big thank you, first of all, to our advisory committee members, Ms. Kelly Holland and Ms. Nina Eisner, for making today's webinar possible with suggesting our guest speaker, Dr. Brian Greenlee from the Ridge. Ms. Holland is nurse by degree and currently serves as Chief Operating Officer at the Ridge, and Ms. Eisner is CEO at the Ridge and has and continues to serve on many boards at KHA. Kentucky SOS appreciates their leadership on the advisory committee. But today, I am delighted to introduce Kentucky SOS guest speaker, Dr. Brian Greenlee. He completed his medical school at Marshall University before beginning his psychiatric residency at Yale. He continued his psychiatric residency training at the University of Kentucky, then entered his fellowship training in neuropsychiatry and behavioral neurology at Dartmouth. After his fellowship, Dr. Greenlee joined the faculty at the University of Kentucky, where he focused on neuropsychiatry and consultation liaison medicine. His areas of interest include traumatic brain injury, movement disorders, and addiction medicine. He is currently a staff psychiatrist at the Ridge Behavioral Health System. I am delighted to introduce Dr. Brian Greenlee. Dr. Greenlee?
Can you hear me now?
Yes.
Okay, sorry about that.
You're fine.
I'm Dr. Brian Greenlee, and I'm going to talk to you today about the neurobiology of addiction, what we call motivation gone awry. My first slide here is just an artistic representation of my understanding of the suffering of the disease of addiction. I've shown these slides to patients in the past, kind of tap into their feelings about what it's like to be addicted, and that incomprehensible demoralization. I think this is worth a lot of the like motivational interviewing once you tap into that. And here you can see this, this gentleman here, the sharks of consequence are circling below. The mast is gone, the sea is raging. He's no longer sailing the ship, he's just surviving moment to moment. And patients seem to attach to art and artistic symbols. So here's my disclosure, no conflicts. And before we start, I do like to reinforce the idea that I approach this from a patient-centered point of view. So I'm just going to read this and talk about it briefly. This is understanding versus explanation. This is from Camus, The Myth of Sisyphus. I realize that if through science I can seize phenomenon and enumerate them, I cannot for all that apprehend the world. Were I to trace its entire relief with my finger, I should not know anymore. So one of the points I'll make repeatedly, and I'll emphasize this about addiction, is that like every mental illness, it affects an individual life and must be understood from the inside out. A scientific explanation cannot replace this humanistic approach. So what is addiction? we'll define our terms here for the point of this talk. Decades of research have revealed addiction to be a disease that alters the brain. We know that while the initial decision to use drugs in part is voluntary, addiction represents a process within the brain that compels a person to become singularly obsessed with obtaining, abusing drugs and other substances, despite their many adverse health consequences and impacts on their lives. So addiction is a compulsive drive to use despite serious adverse consequences. We've all had patients who had something incredible to lose and they just could not stop. We lose control of our intake. There's emergence of negative affective states with abstinence and persistent changes in the brain structure and function. So what are some of the benefits? If there's a cost to the possible humanizing patients, what are some of the benefits of the medical model? Well, this places the disease of addiction firmly within the scope of the medical explanation and treatment. This has reduced stigma both within society and the individual, helping to reduce shame. This also allows a provider at every level to incorporate medical treatment into their areas of care. Overall, this conceptual framework is useful in every aspect of care for providers, for families, for the patient. So, in this conceptual understanding, addiction is similar to other chronic diseases. Using imaging technology to measure metabolism, in this case glucose uptake, in the brain and heart, one can see that both addiction and heart disease produce observable changes in organ function, as evidenced by decreased metabolism. In these images, the healthy organ shows greater activity, the reds and the yellows, than the diseased organ. In drug addiction, the frontal cortex, which is part of the brain associated with judgment and decision-making, is significantly affected. Like heart disease, drug addiction can be prevented and treated successfully. However, left untreated, it is life-altering and potentially life-ending. Like other medical conditions, research has shown that addiction is a complex process, complex disease, influenced by multiple overlapping and interacting factors. No single factor determines whether someone will or will not become addicted to drugs. This goes all the way down the level of explanation to genes and genetic expression, and all the way up to society and the environment patients find themselves in. So why do people start taking drugs in the first place? Research has shown that people generally take drugs to either feel good, either sensation seekers, or anyone wanting to experience a feeling high or different, or to feel better. These are the self-medicators or individuals who take drugs in an attempt to cope with difficult problems or situations, including stress, trauma, symptoms of mental disorders. A patient once told me, he said, if I feel bad, I want to feel good. If I feel good, I want to feel better. So it is a feeling disease. Just elaborate on that a little bit and reinforce this point. Some of the reasons that people express or can be inferred why they use early on in the course of addiction: the experience or enhance pleasure, to alter or intensify mental states, to improve athletic, academic, or sexual performance, or numb negative feelings. So how do we lose the ability to choose? Somewhere along the line, the individual goes from being a casual, occasional, or social user to becoming a slave to their addiction. This is our man in the boat. We will discuss some of the underlying neurological processes that result in this transition. We'll discuss the initial reward and reinforcement, the changes that occur with repeated use, including the loss of our ability to feel pleasure, and the reduction in higher level thinking when it comes to choice. Let's introduce some of the characters of our play here. So we'll meet the players. Dopamine. Everybody knows about dopamine. Patients do, we do, but it's important in this process. We review the critical role of dopamine in the process of addiction and one of the critical pathways. By the time we end this lecture, you'll be tired of hearing the Mesolimbic dopamine pathway or the Mesolimbic pathway. It projects from the ventral tegmental area in the brainstem to the nucleus accumbens in the ventral striatum. We will also discuss the involvement of the amygdala, hippocampus, and areas within the prefrontal cortex. So this slide and the next 3 slides will reinforce and flesh out the role of dopamine, the reward circuits, and their role in everyday life and addiction. Dopamine is a primary neurotransmitter of the reward pathway. All drugs of abuse increase dopamine levels in the brain, and even though sometimes they do so from separate mechanisms, and drugs that are not abused have no real effect on dopamine concentrations in the reward pathway. So, the reward circuits. The final common pathway of reinforcement reward is the Mesolimbic dopamine pathway. The natural stimulation range from mastery, accomplishments, aesthetic pleasure, sexual orgasm. Nature's pharmacy is broad and includes endorphins, anandamide, which is sort of the brain's marijuana, if you will, acetylcholine, and dopamine. Drug-induced rewards hijack these systems, and at levels not seen naturally. So the first 3, nature's way, evolved over a long period of time. A lot of mechanisms to keep it from getting out of control. But the 4th is we can hijack that system. So these are some of the ways that we can activate the mesolimbic pathway, and you can see it's from the ventral tegmental area up to the nucleus accumbens, which is in the ventral striatum. Don't worry about some of these terms. By the time we're finished, you'll have them all. So some of the ways our brain uses dopamine to reinforce behavior are natural highs, to maladaptive behaviors such as process addictions or behavioral addictions, and of course drug addiction. So this is just a more anatomical depiction of the mesolimbic pathway, and it also introduces our first expansion into prefrontal cortex. You can see here from the ventral tegmental to the nucleus accumbens, and it incorporates other areas of the brain. So now back to dopamine. As we have shown, natural rewards stimulate dopamine neurotransmission. Eating something you enjoy, being stimulated sexually can cause dopamine levels to increase. In these graphs, dopamine is being measured inside the brains of animals. Its increase is shown in the response to food or sex cues, and the basic mechanism of controlled dopamine release and uptake has been carefully shaped and calibrated by evolution to reward normal activities critical for survival. So this is a normal, natural process, as you'll see in the next slide, can be overwhelming. So we can hijack that, right? Nearly all drugs of abuse increase dopamine and neurotransmission. This slide shows the increase in dopamine levels measured in animals following exposure to various drugs of abuse. All of the drugs depicted in this slide have different mechanisms of action. They all increase activity in that brain reward pathway, though. So it is because drugs activate these brain regions more efficiently and for longer periods of time than natural rewards that they have an inherent risk of being abused. And you can see here, it just blows through what we'd see around the 200, 150, 200% of baseline reward for amphetamine, cocaine, nicotine, and morphine. So we're going to drill down a little bit. I don't want to talk too much about this. This is a neuron. Most people know how neurons work. We've got our dendrites with their dendritic spines, the axon, and the terminal branches of the axon. So basically, one neuron talks to another neuron, stimulates those dendrites. When enough, it sends an action potential down the axon, and then that talks to the next neuron. So it's the way the brain connects with itself. So this is within the synaptic cleft between 2 receptors. This is a dopamine receptor. You can see the presynaptic vesicles which hold the dopamine, the postsynaptic receptor with its dopamine receptors. So this slide and the one that follows show a neurotransmission works specifically for dopamine. What is schematically illustrated in this slide is the nerve terminal at the top, the synaptic cleft, and you'll see the dopamine being released here. So the natural process Dopamine is released, and it has a reuptake mechanism from the presynaptic neuron, and that therefore is self-limiting for the time and the amount of exposure. So what happens when we do something like cocaine? Well, a couple things. One, it prevents the reuptake of the dopamine, which puts it in a synaptic cleft for longer periods of time and at higher concentrations. So this is sort of just a rehash. Ronald Reagan said the elements of a good speech are to tell them what you're going to tell them what you're telling them, and then tell them what you told them. So we'll go this one last time here. The final common pathway of reinforcement reward in the brain is hypothesized to be the mesolimbic dopamine pathway. This is a center of hedonic pleasure. We call it the James Brown center of the brain. It's the I feel good. There are many natural ways to trigger this system to release the dopamine, but once again, this can become hijacked. So if you walk away nothing more than the information on the slide, I will consider that a win. Good start. So the greater reward system. Now let's begin to expand our understanding of the role of other areas of the brain. So drug-induced dopamine release far exceeds that which occurs naturally. This facilitates greater reinforcement of the behavior, which involves the prefrontal cortex, the amygdala, the hippocampus, and other areas. This creates preoccupation and craving. Repeated use cause more persistent changes that lead to withdrawal and negative affective states. So now we're going to turn to what I call the wow, how, and the what now approach in neurobiology of addiction. So the wow is a dopamine and mesolimbic pathway. The how incorporates emotional and episodic learning leading to craving. And the what now, when addiction is settled in, usually with significant consequences, acute and post-acute withdrawal states create dysphoria and anhedonia when someone's not using. And we lose the ability to choose when or how much we use. So this is the mesolimbic reward reinforcement and learning. As you'll see here, the amygdala, the prefrontal cortex over to the left, and the hippocampus project both ends of the mesolimbic dopamine pathway, the ventral tegmental area and the nucleus accumbens. Upon repeated exposure of the reward system, this path learns to trigger drug-seeking behavior and can remember when confronted with the internal and external cues. You can put patients with addiction into functional neuroimaging, show them a slide of paraphernalia or something associated with a drug of choice, and the nucleus accumbens lights up in anticipation, even before we say the high begins before the use. And this is critical in that idea of preoccupation. Okay, so now's a good time to sort of sit back, take a deep breath, sip your coffee. This slide's not really vital for our understanding of what I'm talking about today, but it does show individual drugs and how they interact with the ventral tegmental area and the nucleus accumbens. So this is kind of beyond the scope of what I can do today, but I just wanted to let everybody take a look at that. Okay, back to the wow, how, and what now. So the wow is drug comes in at step 1. Step 2 is the nucleus accumbens. That's the immediate euphoria. The how lays down these cues. So basically the brain's saying, that was nice, how do I repeat that? How do I do that again? Okay, and this is the memory, the associations, the associative learning, and what we call salience of the event. So above you'll see the prefrontal cortex, and this is the what now. This is hopefully in the beginning where it provides some inhibition and control. So this is another representation of the wow, how, and what now. Same information with a little bit more clarity. Drug ingestion euphoria. Nucleus accumbens, the James Brown center of the brain. The how, the nucleus accumbens signals the amygdala and hippocampus. And the what now, when we consider higher decision making. Is this too risky? Should I try it again? Again, in the beginning, people have a little bit more control over this. So how do we know this? If you're going to get credit for continuing education, then I have to show you, if it's about neurobiology, it's mandatory I show you a slide of a mouse or a rat, and later on some functional imaging. So we either stimulate the ventral tegmental area in a rat or its pathway, or we inject cocaine directly into the brain at the nucleus accumbens, and we create an addicted rat. Now this rat, in an extreme, will choose behavior associated with the relapse, associated with the release or activation of dopamine to the exclusion of other behaviors, socializing, hygiene rituals, even eating. Just for future information, I hope to do another talk on recovery in the community, and I can show you how rats get sober in healthy rat communities. So this is a little bit more complicated version of the last slide. Again, looking at where drugs of abuse have their influence within the brain. This is, again, the brain of a rat. Just take a look at it. So if you're still with me, and if you don't want to lose the thread, you can just ignore this slide altogether. But as shown here, the rat brain, the mesocortical dopamine, I'm missing my laser pointer, systems originating in the ventral tegmental area, the nucleus accumbens, the amygdala, and prefrontal cortex. But then we also have glutamatergic projections from the prefrontal cortex to the nucleus accumbens, the ventral tegmental area. And then they go on with the gamma aminobutyric acid neurons from the nucleus accumbens to the prefrontal cortex. So the brain likes to talk to, all the parts of the brain like to talk to other parts of the brain, and this is sort of how they do it, and how the drugs of abuse can hijack that. Again, I don't want to get caught up in this slide. I'm going to skip this one because I don't have my reference for that one. So this is the neuroimaging slide I was telling you about. This slide depicts images of a brain, human brain. It's taken at different intervals following the administration of radioactive cocaine. I know that sounds bad, but a radio-labeled molecule of cocaine. And because the drug is radio-labeled, we can see precisely where it binds within the brain. See that yellow signal? So there you see it's binding heavily within the striatum, and within the ventral striatum is the caudate, or the nucleus accumbens. So let's expand that out one more time. Research has identified a number of brain circuits that are affected by drug abuse and addiction. These areas are depicted and contained in the circuits that underline feelings, rewards. This is the wow that you'll see in the reward salience part, the nucleus accumbens, and this is the ventral pallidum. The learning and memory, the how, the amygdala and hippocampus, and that motivation and drive and inhibitory control, the what now, the should I do this again, is this worth repeating? And again, you see the interconnectedness of these areas. So we'll talk real briefly about the frontal subcortical circuits. In general, this is the cortical striato cortical pathway. It's just basically a long way of saying these circuits are sort of circular and reinforcing. Three major circuits are the dorsolateral prefrontal cortex, the orbital frontal circuit, and the anterior cingulate circuit. Okay. This is the last of our characters here, so we'll just introduce these, and then we'll kind of try to put it all together. So next several slides do show just some focus on these areas of the brain. So that we're going to start at the bottom here, the anterior cingulate. This is closely associated with the amygdala, and it plays a role in emotional learning. Okay. This provides that emotional salience we were talking about of environmental cues. This is sort of the part of the brain that says, pay attention, this is really important. The orbital frontal cortex is associative learning. So when I do this, I feel that, sort of integrating of emotions, motivation, and that sort of initial, is it worth it? And then the prefrontal cortex, weighing the risks and benefits, starting analyzing outcomes, and this is where we come to, is this really worth this? this ultimately loses influence over the course of addiction, and one of the reasons that addiction becomes so chronic. So this is the dorsolateral prefrontal cortex. You can see where it sits in the brain. People understand that the frontal lobe or the prefrontal cortex kind of is that quote-unquote higher thinking that makes us more human. This is involved in what we call executive function, higher order critical thinking. The orbital frontal cortex, again, this is that where it all gets mixed together. It has close connections with the limbic system, as you can see here. And this is the anterior cingulate gyrus. Again, just wanted to see where it is in the brain and the close connections with deeper brain structures. So we're talking about that, the circular pathways, the corticostriatal-thalamocortical pathway completes the loop. These aren't separate, they're separate areas of the brain, but they're not separate. They're highly connected. Everybody likes to talk to everybody in the brain. And there's an old joke that says, nobody talks to the brain without first talking to the thalamus, so it's incorporated in there as well. So, once again, we're going to put all this together. Reward, memory, learning, motivation, and drive, inhibitory control. Hope you can see that without my laser pointer. So you get a massive reward, the wow. This is the nucleus accumbens. I don't know if, I guess you can see if I do this. This might be a laser pointer for me. This is the nucleus accumbens, and here's the ventral pallidum. Then you quickly learn the connections are sent here to the amygdala and hippocampus. So you quickly learn the how, making associations that are sensitive. They're sensitive to the internal and external cues, which set up craving and associations. This is where, once again, these memories are laid down very quickly, and it kind of tells the brain, look, this part says that was great. This part says, where can we get that again? Let's never forget that. And that is what is set off when you have exposure to a cue or a stimulus, even internal, just a thought. So the prefrontal cortex is then hijacked and overwhelmed and diminishes over time. This creates the problem for the what now. That critical thinking starts to be highly impaired and just overwhelmed by these more primitive systems here. So they just say no. That is another Reagan-era reference for those in the right age category, but Nancy Reagan's just say no. It may have some power early on in the process, but once patients come to our attention, that ship has sailed. Okay, so I've got to switch slide decks here. Okay, I believe that did it. Okay, so we're going to put it all together one last time. Again, this is a great slide that demonstrates those three facts, or those three ideas or concepts we've talked about, these focal points of our previous discussion. Their interconnectedness by anatomically and by processes, all shown in this slide. So once again, we have the nucleus accumbens, that incentive salience, that wow, nucleus accumbens. And again, you can see all of the ways these areas of the brain communicate with each other. And then we have over here it's saying this is the how, this is the laying down in the hippocampus, and then the what now is sort of the executive functional deficits we see in the preoccupation and anticipation. I just want to get a sort of an idea about, again, we talk about these areas of the brain as if they're separate, but really they're highly integrated. Okay, so this is the last schematic of the day. We're adding a lot of complexity here, but the point I want to make, at least for this lecture, is I just want to show you that there is more going on with his processes, the interconnectivity. But if you can walk out with the three aspects we talked about earlier, I'm happy with that. But for motivated learners, there's a lot more to this. I'm not sure that it adds to the understanding, but it certainly adds to the appreciation for the complexity. Okay, so anybody who's dealt with the population with addiction and substance use disorder, we know the frustration, but there's also hope in treating these individuals. So for the remainder of this talk, I do want to talk about that frustration and the other end of that, the hope for treating individuals with addiction. So the prolonged use, or prolonged drug use, changes the brain in these fundamental ways and very persistent ways that make it hard to stop. So often patients can stop, but they can't stay stopped. And there's a reason for that. So just functionally here, this is looking at D2 receptors, and these are decreased over time. You get a downregulation of the postsynaptic D2 receptors. So what happens is, as you can see here, with cocaine, methamphetamine, alcohol, and heroin, that over time, or within the context of addiction, this decrease in D2 receptors, individuals have a difficulty experiencing normal. Remember those back in the beginning we were talking about natural rewards, you know, accomplishment, aesthetic pleasure. The world goes gray for them. They can no longer get this, the normal stimulus does not induce or is not associated with that natural pleasure that we are privileged to. So patients will often tell me that, you know, the world just goes gray. So we're asking them to walk away from their solution to their problems, which is at that point their drug of choice, and we're asking them to go through what I call the doldrums, a period where it's very difficult. They have that decreased hedonic tone, and it's hard for them to feel pleasure. So that's our job, is to walk them through that process. And one of the ways we can do it is educationally. I'm not afraid to bring out pieces of art. I'm not afraid to bring out, you know, brain models to explain to patients what we're up against. You know, why is it that one part of their brain is trying to kill them? So that full recovery is a challenge, but it is possible. Okay, so this is the dopamine transporter. Showed again in neuroimaging. This is a positive emission tomography or a PET scan. So you can see the recovery here, normal control. This is methamphetamine, the second one down, methamphetamine abuser at 1 month. Abstinence. You can see the massive reduction in dopamine transporter density. And then down here, this is 14 months. So we're starting to normalize as far as that one part of the brain. This process does take a very long time. And one of the things we have to sell to our patients is the idea that, you know, in the beginning, yes, things may get worse, you know, emotionally, but we walk them through that process, because as we can see here, as we move forward, you know, 1 to 12 months sober, you know, the risks of the relapse remain very, very high. So we have to sort of incorporate the notion that relapse is a part of this disease. It's a chronic relapsing disorder. So if we can accept that, we can walk people through the process and show them that after a year, their odds go way up. So after a year of abstinence, we're up to 66%. And once we get to 3 to 5 years, you can see it stabilizes. So the magic number for a lot of institutions is 5 years. If you're clean and sober at 5 years, the risk of relapse remains very high. The long-term recovery remains very high. But after about 3 years, and, you know, talking to patients, they'll tell you that, you know, they have that restless, irritable discontent in that first 6 to 9 months. In about a year, they call it the dimmer switch starts coming on. The lights start coming back on. They start feeling more and start getting the connection with people around them, things around them, the life that they used to live. And when people start early enough, they don't have much connection at all. So again, this is a long educational process. So again, addiction is very similar to other chronic illnesses. It has a biological and behavioral components. These both have to be addressed within our treatment. Recovery from it is protracted, absence, and restore functioning. So again, we have to, stop the chaos and start the conversation. As soon as the substances are out of the picture, then we have this individual who sort of has, shattered life. We need to start helping them put that back together. Relapses can occur during, mid, after treatment, and again, to reduce that shame, we explain to patients that this is a part of treatment and not to be unexpected, not to be taken lightly, but not to be unexpected, and sort of get them, reorient them, get them back, maybe adjust our treatment or just reinstate the treatment you had. And again, the goal is long-term recovery, sustained long-term recovery, so that the brain can begin to heal and readapt to normal pleasure, normal stimulus, and those higher level critical thinking skills coming back so that people can start engaging their life once again. Okay, so I'm going to end with a quick Emily Dickinson poem and talk once more about that humanistic perspective. So the brain is wider than the sky, or put them side by side, the one the other will contain, with ease and you beside. The brain is deeper than the sea, or hold them blue to blue, the one the other will absorb, as sponges buckets do. The brain is just the weight of God, or heft them pound for pound, and they will differ, if they do, as syllable from sound. So again, Emily Dickinson and the notion here is we're talking about the brain today, but let's not forget for one moment the individual lives that are at the center of this. Talking about the neurobiology, I don't want to escape the real impact this has on unique individuals who we're trying to help on a daily basis. And that's the end of my lecture. Be happy to take any questions. I see a chat box, but I don't know how to use it. It's been kind of, let's see here. I don't know how to use the chat box.
You're fine. Thank you, Dr. Greenlee. This is Emily again. Are there any questions for Dr. Greenlee today? He has offered to provide his personal email, which I have just posted in the chat box for your use for if you think of something later. But please utilize the chat box if you have any questions currently.
And at this time, all lines are open. You can unmute your phone by either hitting *6 or the mute button on your phone. You can also put your question in the chat box like Emily said.
While you are thinking of your question, this webinar today did start a 4-part series for Kentucky SOS on behavioral health issues, and Dr. Greenlee will present the 4th webinar of this webinar series. So more to come on this topic.
Yeah, especially if we want to see how the rat gets sober.
There you go. Okay, Dr. Greenlee, we do have a question, please.
Okay.
How does MT help the brain heal, which is in the chat box?
Okay, where is it?
In the chat box, the question is, how does MAT help the brain heal? You don't have to type a
Okay, the short answer is I tell people that, look, MAT, buprenorphine, Suboxone, all it does is help you stop the chaos so you can start the conversation. It's not a replacement for long-term recovery. It doesn't really help the brain heal. What it does, keeps people out of jail and keeps them above ground long enough for them to find this long-term recovery that we've been talking about. So again, I tell people all the time, look, Suboxone is a bridge to long-term recovery, but if you don't do the long-term recovery part of it, it becomes a pier, you walk right off the end of it. So what we use with the Suboxone is essentially to, keep them, again, alive and out of prison, and stop some of the more severe consequences of their life, so that once that chaos dies down, you can start that conversation. But it does not replace the conversation, and no, it does not facilitate healing. It stops the continued damage or harm, because as we all know, people, they're not buying high-grade pharmaceuticals. When people take substances on the street, it's mixed with methamphetamine, cocaine, fentanyl. So again, we stop that damage, ongoing, stop the chaos, start the conversation. Thank you.
Are there any other questions for Dr. Greenlee? We have another one, Dr. Greenlee, in the chat box. Any tips, resources for patients to share with their family to teach this chronic brain disease model to reduce stigma?
Yes, NAMI has a significant amount of patient-oriented literature looking at various mental illnesses as concepts of a brain disease. And again, I hesitate to use that term, but it does have its use for patients and their families. And also, NIDA also has some patient-oriented materials that you can get off their website. I don't know the website offhand, but I'd be happy to if you email me a question, I'll be happy to get all that information to you. And in my office, I always have a model of a brain, and I usually have various pieces of art. Once again, to get people talking about that, if they can find that incomprehensible demoralization, then it leverages that that ambivalence. So it's very helpful.
Okay. We, while others are thinking of questions, as mentioned, like previous webinars, this is recorded, and the slides and recording will be emailed to all project leads. Also, it will be posted on the Kentucky SOS website. Live participants will receive or can receive continuing education that's for medicine, pharmacy, and nursing. You see on your screen today the continuing education portal that you can use to get 1 hour of, to receive 1 hour of continuing education. Please be mindful that this portal does end September 26th at 11:59 p.m. Eastern Time. When this closes, we are not able to provide any more CE. This is through a third-party vendor. So the portal does close on September 26th at 11:59 p.m. That's for pharmacy, medicine, and nursing. And I am delighted to say that I received approval earlier this morning from KBML for House Bill 1 CE credit for our providers. I have included that ID number in the chat box for you to get HB1 CE credit. If you by chance are on the phone and are live on or listening live to this webinar and you do not see the CE information portal or the House Bill 1 CE ID, please contact me, Emily Henderson, by email at ehenderson@kya.com, and I will provide this information for you. The Kentucky SOS website is a wonderful website for tools, resources for this event and for past educational events. Please go to Kentucky, spell out KentuckySOS.com. And are there any last questions for Dr. Greenlee today? Okay. Please don't hesitate to contact him by his email. Again, that is in the chat box that I provided earlier. And I will also include that when I emailed the slides and recording to the project lead. Thank you so much, Dr. Greenlee from the Ridge Behavioral Health System today. Really appreciate your education on the neurobiology of addiction, and we look forward to the future webinars regarding